Good afternoon, ladies and gentlemen. On behalf of Mike and I invite you to the Lunchbox Symposium on Lung Volume Reduction Surgery. Could I just get everybody to move in closer so that it's closer and cozy? We have three excellent speakers. We have Professor Morgan, who is a colleague of mine working at the University Hospitals, to give us a brief introduction into case selection and working in an MDT setting, following which we have Professor Felix Hirth from Heidelberg to give us an overview on current endobronchial options available for management of volume reduction. And we then move on to the surgical ones by Professor Dirk van Ramdonk from Leuven, Belgium, who will give us an overview on both surgical LVRS as well as the role of transplantation in emphysema. Could I invite Professor Morgan to kick off? Mike is a professor of respiratory medicine and chest physician in the University Hospitals of Leicester, as well as the national lead for emphysema strategy, COPD strategy. He advises the NICE, and he will give us an introduction on advances in management of emphysema. Thanks, Mike.
Thank you very much, Sri, and thank you very much for coming this afternoon. The task that I've been given is to discuss the assessment and case selection of patients for lung volume reduction procedures in a multidisciplinary setting. It's always a privilege for me to be invited to talk at surgical meetings because as a respiratory physician here, I feel entirely comfortable in your presence. But actually, there is an advantage to being a respiratory physician, particularly one like me who doesn't do any procedures and no longer even does any bronchoscopies, because I can retain a neutral status when it comes to considering selection issues and also considering the choice of procedures. So when you're asked to consider selection for lung volume reduction procedures, the assessment is actually on several levels. It includes the general suitability of the patient in terms of their condition, their presenting condition. It includes an assessment of whether their management is optimal and current, something about whether you can predict the benefit in an individual case so that you can discuss that with the patient, and also to have an assessment of the risk of operation and the risk of perhaps of failure with that patient. We also now have the benefit of a choice of procedures. And finally, of course, we have to discuss in these days with the patient, with the informed patient, about decisions at every stage of the process. So I'm going to go through this with you and just describe how, over the years, we've evolved a system that involves several disciplines when you come to these decisions. I'm just going to go back to the nature of emphysema, which is the disease that we're dealing with, and just make sure that we are clear about the background. Chronic obstructive pulmonary disease, of which emphysema is part of the spectrum, is a diffuse condition. It's characterized by presence of airflow obstruction, but it's in fact many different conditions. And all these patients whose scans you see here have got COPD with a similar level of airway obstruction. This patient has small airways disease. This one has generalized emphysema, and this chap has got bronchiectasis. But they all have a similar FEV1. So you can't characterize patients solely on the basis of their airway function. If you inhale noxious substances, there's something about hit and miss as to what part of the lung, what part of the airway that gets damaged. And this seems to vary from person to person and isn't directly related to the nature of the noxious substance. So if people, for example, inhale cigarette smoke, they may get damaged pathology to the large airways, which results in airway thickening and cough and sputum and mucus hypersecretion. They may get small airway damage with inflammation and with wheeze and breathlessness. They may get parenchymal damage leading to emphysema, and they may get pulmonary vascular damage leading to pulmonary hypertension or respiratory failure. Now, it's never quite the same in patients as to which area is affected most. But the area that we're considering now is around emphysema. And the pathology in emphysema primarily results from alveolar wall destruction, the aggregation of large spaces, and importantly, the loss of elasticity, which leads to lack of support of the airways and airway obstruction. Now, hyperinflation is the hallmark of emphysema. And hyperinflation is actually a compensatory mechanism for the loss of elastic recoil. It's an active process where the tone in the respiratory muscles holds the chest wall at a higher lung volume to mitigate the airway obstruction by maintaining airway patency wherever possible. Of course, there's still airflow obstruction present, and the very presence of hyperinflation itself is uncomfortable. If you hold your breath and try and take a breath from that, you'll notice the discomfort. But the resulting changes in geometry result in inspiratory muscle dysfunction through changes in geometry, a loss of neuromechanical coupling, particularly around the area of apposition to the diaphragm. This static hyperinflation also increases on exercise and results in dynamic hyperinflation, which I'll explain a bit later. It also increases the work of breathing and can also have an impact on venous return and cardiac output. Now, hyperinflation is a feature of all obstructive airways diseases, from small airways diseases to giant bully. But only some of these are surgically amenable. We know about bully. We're learning about heterogeneous emphysema. We know a little less about homogeneous emphysema. The hyperinflation that occurs during exercise is probably the cause of the ventilatory limit for most patients with severe emphysema. If I just explain that a little more, if a normal person here, if they exercise, will increase their ventilation with exercise. But they do so by increasing their tidal volume and respiratory rate. But importantly, the end expiratory lung volume remains static. If you have emphysema and you're already hyperinflated, and you start to exercise, your ventilatory requirements mean that you increase your tidal volume, but unfortunately you can't empty your lungs in time for the next breath, so your end expiratory lung volume rises, and your inspiratory capacity between your end expiratory lung volume, or your total lung capacity, your end inspiratory lung volume and your total lung capacity comes up against the buffers. So these patients have a true ventilatory limit. Also, if you're breathing under those circumstances, the pressure-volume characteristics of the lung are such that it is extremely tough to breathe. The pressures required are greater, and therefore the energy costs are greater. So it's very uncomfortable. The aim of lung volume reduction surgery, therefore, is to remodel the chest in order to improve or reduce static and dynamic hyperinflation, and also to improve neuromechanical coupling. And it does so here by increasing the curvature of the diaphragm, but also primarily by improving the area of apposition of the diaphragm. Now, the evidence for benefit for lung volume reduction certainly comes from a number of trials. And there have been several trials over the years, randomized controlled trials, but you'll see that the evidence base is dwarfed by the National Emphysema Treatment Trial, which was published in 2003. This was a very big trial, and I'm sure you'll all know about this, but it randomized over 1,200 patients with severe emphysema after they've had rehabilitation to volume reduction surgery or usual care, and followed them for 24 months. Their main outcomes were survival and exercise performance, but they also measured lung function and health status. The bottom line was that people with upper lobe predominant emphysema and poor exercise capacity had survival, exercise, and health status benefits. They also identified a number of patients where there was a relatively high risk of surgical failure and operative mortality, and these were patients with low FEV1 or gas transfer and non-upper lobe emphysema. Now, what happened next, I think, was unfortunate for the history of lung volume reduction surgery, because prior to the publication of the main paper, a paper describing this risk was published also in the New England Journal of Medicine. And they described that these high-risk patients had a 16% 30-day mortality, compared eventually to the overall net mortality of 5%. The title of the paper, however, Patients at High Risk of Death After Lung Volume Reduction Surgery, is more akin to a Daily Mail headline than it is to the true nature of the paper, which simply describes that some patients were high risk. But I'm pretty sure that this put off a whole load of people from referring patients or undergoing lung volume reduction surgery. These days, we're much more sophisticated about the risk, and my colleagues at Glenfield, and Neil Greening is going to present this at this meeting, have come up with a modern score of operative risk with which to inform patients. And they've looked at over 200 patients here, and they've had a scoring system of which the primary components are BMI, gas transfer, and airway function. And they find that in patients with a low score, the operative mortality here on 94 people was 0. And their long-term outcome was also pretty good. The normal risk category had a 30-day mortality around the same as the net, a little bit less, and the high-risk category, again, about the same, but a little bit less. So you can now have a much more sophisticated discussion with patients about their individual operative mortality. The other thing to note about operative mortality in lung volume reduction surgery is that if you survive the operation, however bad you are, they all seem to do the same. And this was a study from Joel Cooper's unit where they did operate on some high-risk patients and they compared them to all the other patients. And providing they survived the operation, the survival curves were similar. So if we look back at the net now, and remember this was conceived, carried out and conducted almost 20 years ago now, there are some questions, I think, which we must ask about it. The one that I have is that I don't think the rehabilitation was particularly effective, since it's one of the few rehabilitation studies which didn't show a positive benefit. At the same time, there were new centres who were learning how to do the surgery. The outcomes that they choose, particularly laboratory exercise tests, are not a particularly responsive one. I don't know why they chose survival, because survival is not something that we discuss as a primary outcome with patients when we're discussing it in the clinical setting. There's an awful lot of post hoc analysis, and I think there's something upwards of about 70 papers that have come out of this trial, and they're still producing them. Also, they looked at upper lobe predominant disease, and I think that was probably to do with the way that the surgery was conducted rather than the way we look at it now in terms of target areas, and that surgical techniques have moved on. Most centres in the NET trial did median sternotomies and bilateral volume reduction that way. Nevertheless, the NET, because of the weight of evidence, the NET recommendations are carried through into our own clinical guidelines. And the current NICE guidelines continue with this, saying that all patients who are disabled in spite of maximal treatment should be referred for consideration of volume reduction surgery in this case, unless they meet the high-risk criteria. Actually, you should still probably refer them, and it's for somebody else to consider the high-risk criteria. So when it comes to selection for lung volume reduction procedures or lung volume reduction surgery, the tools of the trade are lung function measurements, distribution of emphysema by some imaging, and the measurement of exercise performance. Clearly, there are some outstanding exclusions if people have got very bad coronary artery disease or pulmonary hypertension, or they've had previous surgery. They may not be suitable for surgery, but they might be suitable for other techniques. And at the same time, we have to be sure that we can measure an outcome from our procedures, and therefore they need to have baseline measures of lung function, exercise performance, and health status. Now, I just want to say a brief word about lung function testing, and this is what our lung function tests look like. They report on airway function, on lung volumes, here measured by plethysmography and helium dilution, and gas transfer. This particular patient has very severe airflow obstruction, an FEV1 just over half a litre, a flow volume loop with a pressure-dependent appearance characteristic of emphysema, and impaired gas transfer. What's important to recognise is the method in which you measure their lung volume, because if you measure it by helium dilution, this chap's lung volume is 4.5 litres. If you measure it by plethysmography, it's almost 3 litres bigger. So if you're going to consider a patient for lung volume reduction surgery, you need to measure their lung volumes with plethysmography and not by gas dilution. We generally use imaging techniques for understanding the nature of heterogeneity or lack of it. Usually CT scanning, either using a visual assessment by the radiologist. There are various visual scoring systems, and there are some automated ones. I think most people are happy with the radiologist's view or just a simple visual appreciation of the scan. We also use perfusion scanning because it just adds another dimension to the topography here, identifying low perfusion areas here in the upper lobes, the right side of which might be more suitable. You can also score this mathematically in addition. In terms of assessment of disability, you're looking for patients who are significantly disabled. Now, you can judge that in the clinic from the MRC score, and you're looking at patients who are in the 3, 4, and 5 range who have significant impairment of activity. In terms of assessing their exercise performance objectively, I think it's perfectly reasonable to stick to field walking tests for two reasons. Firstly, because they're easy to do, and secondly, because they are a more sensitive outcome than cardiopulmonary exercise testing. However, the benefits of doing cardiopulmonary exercise testing in the laboratory is that they might identify the nature of the limitation, and hopefully it would be ventilatory. So if you want to prove that, then you would have to do a laboratory exercise test. One of the things that I find most difficult is to give patients advice about what the duration of benefit might be in their case. And I didn't know where to start, but if you look at operations for giant emphysematous bully, then that's probably the best circumstance in which you'd expect the best outcome. And some work done more than 30 years ago now in Liverpool identified that patients who had a bullectomy for traditional indications had an improvement in lung function which lasted somewhere in the region of 8 to 10 years. Now, you wouldn't expect to get that degree of benefit from heterogeneous emphysema and lung volume reduction surgery, but you might get something in the region of 3 to 5 years. So when I discuss this with patients, I say that they could look back to what they were doing 3 to 5 years ago for some indication of the benefit that they might get if the operation goes well. So this is the schema that we have for a multidisciplinary assessment for lung volume reduction procedures, and I've swiped this slide from Sri. Patients are referred, and they're usually seen in a sort of an assessment phase by a respiratory physician or perhaps a thoracic surgeon. They have a fairly broad discussion of the risks and benefits, and if they're agreeable, then they go and have their specialist investigations. When they've had those done, we have a regular lung volume reduction multidisciplinary team meeting and discuss each of the cases and decide whether they're suitable or not suitable. If they're considered to be suitable, we will ensure that they've had proper pulmonary rehabilitation, and they'll then have a more detailed discussion about the risk and the procedure, an individual risk and procedure with a thoracic surgeon. At that point, some of them may even decline treatment. I can't imagine why, but that happens. Others may go through and have VAT surgery. These days, we've got other options. So some patients who decline surgery because they don't fancy it may be pointed towards other techniques, and also high-risk patients where the surgical risk might be high might be considered for, in this case, for endobronchial valves. First of all, of course, they do have to have a procedure to identify whether collateral ventilation is present or not, and if it is present, then they might go around the system again. So that's how our system works. Of course, we record every one of the MDT meetings. We have a core team which includes thoracic surgeons, physicians, radiologists, and the pulmonary rehabilitation staff, and we have somebody to coordinate this. And here's an example of a patient here who's discussed. He's got MRC score 4, so he can only walk 100 yards without stopping. However, he's got recurrent exacerbations. He's going for rehabilitation. He's had his investigations. He's got a low-risk score, but he's in the middle of an exacerbation there. So we're not going to consider him for the moment until he's better. So he goes forward to another meeting. And also there's a complication there because the most recent CT scan shows some pleural thickening and effusion possibly related to old injury or previous surgery. So it may be that he's not an ideal case for immediate surgery. So we will keep on discussing him until it becomes clear. Now, over the years, and we've been doing this since 1995, we thought, as most people did initially, that volume reduction surgery would open the floodgates to a large number of patients. There were initially quite a large number of referrals, but the number of procedures done in green there has actually remained fairly constant at about 25 a year over the last few years. What's interesting is that the ratio of procedures to referrals has started to fall. So I think our referrers are getting much cannier about identifying the patients that might benefit. I still don't think that they recognize enough patients to refer, but at least they're getting better at referring the right ones. The other thing that's happened in recent years has been the availability of other lung volume reduction techniques. And NICE has just pronounced on the use of endobronchial valves, which appear to have some benefit. They're also, of course, not without side effects either. But their advice now is that other endobronchial procedures should be considered in exactly the same way by selection by a multidisciplinary team, which should include a surgeon so that the surgical option is discussed. They're inserted by clinicians with specific training, and the trusts themselves have a duty to understand that this is a developing or innovative procedure. It's not entirely tested yet, and the patients must understand that this is to some extent an experimental procedure. And clearly more research is needed, and my view is that the particular comparison should be between those who have a low risk of surgery and valves as to whether which would be the best procedure. So if I summarize where we are with the selection process for lung volume reduction, we have a general suitability, which includes patients with hyperinflation, heterogeneous emphysema, and activity limitation. There's a sort of age limit, but not really. Once you've excluded any major hazards, then they go through to an initial risk and benefit explanation, then they go for rehabilitation, then they go for a detailed multidisciplinary discussion and a surgical interview. They have the procedure, and it's very important for quality improvement to ensure that you remeasure or keep tabs of their outcomes so that you understand how your program is doing. What is most important at every step is that you have an informed patient choice, that the patient understands what's going on, and they do have freedom of choice between whether they go ahead or what procedure, in fact, that they have. Just a brief word about rehabilitation, because rehabilitation is a key component to decision-making about volume reduction surgery in particular. Firstly, because the patient becomes informed during the process of rehabilitation about decision-making. And secondly, some may have a functional improvement, which may be enough for them to reconsider the risk-benefit discussion. And finally, there's an opportunity to get them as fit as possible for surgery and try and address smoking cessation and other issues. So the last two slides then are considerations. Firstly, emphysema is a condition which affects not only patients, but it also affects the carers and the health community in terms of their disability, recurrent hospital admissions, and the like. Then people with advanced emphysema, of course, have a relatively limited lifespan. So something which gives them benefit for 3 to 5 years may not seem very much to someone who's able-bodied, but to somebody who's got emphysema, that is a considerable proportion of their remaining life. Now, COPD is common, but actually the suitability for lung volume reduction procedures has turned out to be fairly small. The operative risk is high, but an individual may well consider it well worth the risk. But people vary considerably, and therefore they have to be given the opportunity. So we think that multidisciplinary assessment is the key to success. I'd like to be sure that we demonstrate a ventilatory limit to exercise or dynamic hyperinflation on every patient. But we don't do this for practical reasons. The target is heterogeneous emphysema, not necessarily upper lobe emphysema, and we have had success with lower lobe target areas. And these days, the identification of collateral interlobar ventilation may determine which technique you offer the patient. The most important thing, however, is that the patient should always have a view. Thank you very much.
Do we have any questions there for Professor Morgan? Question there.
Hi, Douglas West, Bristol. We've got valves now for people who are collateral ventilation negative. We're going to have coils for people who are collateral ventilation positive. And the initial data from the coils suggests they're quite safe. What's the role for surgery in the future?
Surgery is gold standard. We know that it works, and we know increasingly that the risk is small if the patients are well characterized. There are no trials so far of any of these endobronchial procedures against surgery. So we don't know what the true comparison is. And as ever, when you bring in any innovation, the first trials are likely to be optimistic. You know, you get the action potential of enthusiasm followed by depression about something. And there are quite a few opportunities, and I'm sure you'll hear about all the endobronchial opportunities. What I would say is, firstly, that I don't think anybody should be considered for any sort of volume reduction procedure without considering the whole range of treatments available to them. And the danger, of course, with endobronchial techniques is that somebody who is not a surgeon might carry out on their own without any suggestion to the patient that there might be a reasonable alternative, and perhaps, in my view, because of the historical data from the net, overstates the surgical risk. So I mean, it's very interesting developments. Cost-wise, there's not been an economic comparison. They're all treatments in development, so I'm not going to commit myself to one or the other. But I think what NICE have said about endobronchial valves will equally well apply to coils, glue, steam, blood, or whatever else is coming along. Yeah, they're all interesting, and some of them may prove helpful in some patients, as long as the thing is considered as a whole.
Do you have another question? Do you have a question, Babu?
I think the gentleman over there is first. Got his hand up, yeah.
Hi, Sean Bonner from Newcastle. I agree that we, certainly in the North East, are not getting anything like the numbers you're getting in Leicester, because I think you've developed the service through the MDT. I was interested in your higher scoring group, higher risk group.
Yeah.
They are reflecting stuff we're seeing in lung cancer nationally, that the 30-day mortality is half the 90-day mortality, or if you look at it the other way around, 90 days mortality, over a quarter of patients are dead in the high-risk group. What's happening between 30 and 90 days in this high-risk group? Do you have a feel for that?
Not specifically for the surgery, but when patients are admitted to hospital with COPD anyway, they have a sort of vulnerable period when they're discharged, and that's actually beyond 30 days. It may be 2 or 3 months, at which they sort of are at risk from readmission. And I think it takes a long time to get over any sort of major surgery, particularly if you've got underlying lung disease, and they are vulnerable. So I don't have a specific explanation, but it doesn't surprise me that there's a significant attrition rate. If you have an admission to hospital with COPD, your chances of surviving 3.5 years are 50%. So you're going to lose a lot of people. But that's the point I'm making, that actually the benefit here must be seen in terms of a limited lifespan by the time patients get to this stage.
I was just thinking that what I do in the few cases I do, I tend to move them into the spring and summer months.
No, we do that. Yeah, we try and avoid operating during the winter season, and patients understand that. Actually, they sort of respect you for doing that.
Hi there, Babu Naidu, thoracic surgeon. I'm over here from the Birmingham Heartlands Hospital. One of the things that surprised me in my limited experience of this is the occasional lack of concordance between homogeneity assessed on CT versus VQ scan. I just wanted to get your expert feedback on that.
Well, I'm not a radiologist, but I mean, that's why we do the perfusion scans as well, because as you say, sometimes the target areas look more obvious on one than the other. We don't do any automatic scoring of CT scanning, and I wonder if we did, whether we might have a better concordance, because it is very much down to the radiologist's opinion as to the heterogeneity of emphysema on the CT scan. I mean, sometimes it's clearly obvious.
I mean, do you ever, based on CT findings alone, refuse?
No, I don't think we do. I think every case gets a perfusion scan.